ठीक है. Good afternoon, everyone, and welcome to another edition of Ask Max Expert live session. Today we have Dr. Rajesh Elawat, Group Chairman Urology and Chairman of Center of Excellence of Prostate and Urological Cancers and Male Health at Max Hospital, Sector 128, Noida. Dr. Elawat specializes in urology, kidney transplant, uro-oncology, and robotic surgery. Today, we will discuss about Focal One, advancing cancer care through innovation. So, doctor, over to you.
Thank you very much for the opportunity. Let's start with talking about prostate cancer first, because that's where this Focal One fits in. Prostate cancer is one of the second most common malignancy in India, in men. It's epidemic world over, and it's expected that 1 out of 8 men in UK, they estimate, is going to have prostate cancer. Look at the amount of volume that the disease affects. 1 in 5 men in Australia is estimated would be having prostate cancer. In India, the incidence is said to be lower, and the published data and the amount of data that we have, it shows that approximately 1 in 125 men has prostate cancer. But I think it's more because we do not diagnose the disease. The data, there are no registries. We are not reporting all the cancer prostate patients. It's being diagnosed only in larger hospitals, in larger cities, while many patients go undetected and undetected. So we have a large problem of prostate cancer, and this disease, being so common, has a very wide spectrum. So at one end you have the disease which does not require treatment, or where the treatment could be more detrimental than the disease itself. And on the other hand, you have the disease spectrum where you have to run after the disease with all the modalities that you have. So you have a low risk disease, you have an intermediate risk disease, and you have a advanced disease or a high risk disease. As we are detecting more and more early cancers, because with the PSA screening, now that you have a blood test which can detect prostate cancer early, we are diagnosing more patients early. So we have many patients who are coming now in early part of cancer, early detection of cancer. And since we have early stage cancer, there are many patients now who have a low risk to intermediate risk disease, which require no treatment, or require a treatment which should be not as radical as is required by the advanced disease. So the advanced disease, you have surgery and radiotherapy and hormonal therapy to treat this disease, while on the other hand you tell the patient that you have a disease but we don't want to treat you and you can go back home. So it's a big anxiety for these patients. And apart from the anxiety, sometimes even as a clinician, you are not sure whether this disease should be left alone or should be treated, and we are on the side of radical treatment. And once you offer a radical treatment for this disease, there are attendant side effects, and the major side effects that affect people with radical treatment like surgery, radical prostatectomy, or radical radiotherapy is the effect on their continence, that is the urinary control. They have many of these 15 to 20% of patients will continue to have some degree of urinary incontinence, and even the larger hit is taken by the sexual function. Approximately 70% people lose their degree of potency, if not complete potency, and it's said that many of them would be able to recover part of their sexual function with the help of medications, and as long as it may take as long as a year or longer for that recovery. So look at the amount of side effects that the radical treatment has. And when we have the patients with a low risk or intermediate risk disease who require treatment, and you have nothing except radical treatment to offer them, there was a big lacuna, there was a big gap in the treatment. And that is where we have brought, and world over it is being realized that there was a big gap which has to be filled by a local treatment, and as has been the treatment of most of the diseases, like you see breast cancer or the kidney cancer, where the organ was being removed for detection of a disease. Now what we do is that we remove only part of the organ which is diseased and leave the rest of the organ behind and supplement it with treatment, and you have the functional outcome of the organ which is preserved. You treat the kidney cancer by removing just the cancer and preserve the rest of the kidney. In prostate, we were removing the whole prostate, and if we just have that part of the disease treated like rest of the organs, organ preserving treatment for the cancer, it's possible only in the also in prostate also. Second thing is the theory of index lesion. So the prostate cancer can be multicentric. This can be start at many places within the prostate, but it is only one area or one small area of the prostate disease which spreads and which is going to harm the patients. And if we can recognize this part of the disease and treat it, just that part of the disease, then this disease would not progress. And with the advances in the imaging that we have had in last 10 years or so, with the advent of multiparametric MRI and PSMA PET, we are able to localize that small part of the prostate which is diseased now. You can with confidence say that this is the part of the prostate which is diseased, and if this is treated, then it's likely that we will be able to get rid of the disease, or we can stop the growth of this disease. And here is where the local treatment or focal treatment have stepped in. There are many ways in which we can treat prostate with focal treatment. You have various energies. You have HIFU, which is high intensity focused ultrasound, which is used by the focal one, the machine that we are going to talk about. You have a cryo, where you can make the tissue or precipitate, you can have iced that part of the tissue. You can have electroevaporation, which is called IRE, and there are other modalities also, which can be used to focally treat a tissue for which contains cancer. But the most extensive experience of all of these has been with HIFU, and the HIFU with the focal one that we'll be talking about today, or we are talking about today, is a machine which uses the high intensity focused ultrasound to treat that part of the prostate using a robotic arm. So we are able to see the imaging, advanced imaging with ultrasound. We are able to infuse the MRI images onto it, and we are able to identify the area of the prostate which is diseased, and then robotically this area is handed over to the HIFU energy, and with intermittent checking, this area is treated by the high intensity focused ultrasound, saving the two big nerves, saving the urethra, saving the sphincter, so that you have the outcome which does not affect the functional outcome of the prostate, which is that you should have good continence at the end of the treatment, and you should have good sexual function remaining with the patient. And with that, I'll request if there are any questions, I would be happy to answer them.
Thank you, doctor. We have a couple of questions coming in from the audience. So the first question that we have is, to start with, what is prostate cancer and how common is it among men today?
I think I covered a bit of it early in my discussion when we were talking about. So it's the second most common cancer in man, It's one of the top cancers in men all around the world, and the incidence in India is increasing because of the awareness, because of PSA screening, and because we are able to detect it. Previously, we used to have patients coming in only in the advanced stage, and there was a time when people used to say that in India you don't see this disease early, and there is no role of prostatectomy or early treatment. But we see a plenty of patients coming in now in large numbers in early stages, and the number of prostate cancer is increasing in every hospital and every clinic now.
Thank you, doctor. Another question we have is, uh, why is early detection so important in improving treatment outcomes for prostate cancer?
That's a good question to ask, and the answer to that is that if there, as I said, that there's a large spectrum of the disease, and you have, once the disease spreads, it will spread. It's in a small area. It's in one part of the gland, then it goes to the second part of the gland, becomes bilateral, then it breaches the capsule, goes extraprostatic, then it invades the adjoining organs like bladder, seminal vesicles, and with each of these happening, the chances that you can have a prostate cancer free patient after the cure becomes lower and lower. So if you detect the disease early, it's possible to have 100% cure, but as the stage of the disease, as we call it, once the stage migration occurs, that it involves adjoining organs and goes out the prostate, it involves lymph node nearby, the chances of cure become less and less. Secondly, that if you treat such a disease which is extensive or extraprostatic, you have to, as a part of the cure, you have to remove more and more, and the fight is to remove less and less, and you have a better outcome, better functional outcome. But if you remove more, the functional outcome of having a poor urinary control and poor sexual function after the surgery becomes more and more. So that's why it's important to detect the disease early and treat it at a stage when you can give 100% results, you can have the least amount of side effects, and you can have a cure of the patient, which is possible.
Thank you, sir. We have another question, like the way you said that early detection is very important. I think we hear this a lot, that some symptoms can be detected at individual level. I think that's the first point to understand how it has all started. So, what are the early signs and symptoms, that an individual should not ignore?
Another important question, that disease is completely asymptomatic in its early stage. There are no symptoms when you can disease, and there are so many patients who come up, I don't have a symptom, and I am being forced into investigations. So in early part of the disease, there are no symptoms are likely to be there. And if you wait for the symptoms to occur, like urinary obstruction or pain or later other symptoms of the disease like weight loss and fatigue and all that, these are very late symptoms. So the crux of the early diagnosis is detection, early detection. You identify a patient, you pool of patients who are more likely to have this disease, like after 50. We say that one should screen a patient with PSA till the age of 70 every year. If you have a family history of prostate cancer or breast cancer, the screening should start at the age of 45. So you catch them early. So that's the crux of the disease, crux of the matter, that if you want to detect the disease early, don't wait for the symptoms. And it's usually in the very early symptoms of urinary symptoms like normal prostate or PSA, which tells you that the disease could be there.
Thank you, sir. There are a couple of more questions. The next question is, there are still patients who are going through the symptoms. They are not well aware about the treatment options. So what are the treatment options we have traditionally have been available for prostate cancer patients?
Yeah, so some of it I have covered earlier. So, you have a whole spectrum of disease and you have a whole spectrum of the treatment, so early part of the disease or early, the low risk disease or intermediate risk disease or a high risk disease. So, in low risk disease, we usually say that, you do not need the treatment or we need to have a frequent follow up, and we call it active surveillance. So, when you do active surveillance or watchful waiting for these patients, you keep on monitoring them. You can even repeat your MRI or you can repeat biopsies in these patients, and it is expected that you can save approximately 60%, 50 to 60% of the patients from any invasive treatment or long term. On the other hand, for the invasive disease, you have the neoadjuvant treatment or medical treatment where you can shrink the disease and subject them for radiotherapy, and even for surgery now the neoadjuvant treatment has started. So, you want to treat the disease and do surgery for these patients to get rid of the disease. But as I said, that both surgery and radiotherapy, the side effects are the ones which bother everybody. And people who have been treating prostate cancer for a long time, they usually, most of them have been trying to get into that niche where between the no treatment and this radical treatment, that where they could offer the patient the treatment which is needed only to that part of the prostate where the disease is present.
Thank you, sir. We also, since the session is all about talking about the focal one, which has been, an advanced technology, what makes it a breakthrough in prostate cancer treatment? How it is, used as how it different from conventional treatments such as surgery and radiation therapy?
So, again, so the focal one, which is the one of the methods of doing using HIFU, that high intensity focused ultrasound. You take it as a, if you the child, you as a child, many of us have played with the lens and through a sun trying to burn a paper or something by focusing the beam. It's the same principle, that if ultrasound energy is used every day, it's a harmless energy otherwise, but you can focus it, and if you focus it, it can produce the amount of heat which can destroy the tissue. And this is called high intensity focused ultrasound. This technology is not very new. It's very old technology, I say approximately 10 years old technology when it was started to use prostate cancer. But unfortunately, during this period of evolution, what we have had, what we did not have initially was the imaging. So multiparametric MRI, PET imaging, they have allowed us to distinguish the disease or identify the disease in a small area where the energy can be focused. That's number one. Number second is that during this phase of development, we realized that even with this energy, you can cause side effects. And we wanted to have a safe energy delivery. And that is what focal one does. That you can, you have a cold fluid running in the rectum, which protects the rectum from injury. You can identify the urethra, you can identify the sphincter, you can identify the bladder neck, and once you mark these areas on the screen, the energy is going to remain away from these areas, and that's how you can save these and make this treatment safer. The third aspect of this focal one is the delivery, method of delivery, that it has a robotic arm. With the robotic arm, once you have fixed the patient, once you have, you take up the images, you fuse the MRI images onto that, you identify the lesion, you generate an area where the energy is to be delivered, which is away from the sphincter and the nerves and the urethra and the rectum, and then you hand it over to a robotic arm. And this robotic arm, over a repeated sessions, 5 sessions, it delivers the energy to it to treat that area, and intermittently you can see it live on the screen, and you can intermittently fix the areas again, if the patient has moved. In addition, it has also identifies, it has a movement detection arm. So if there is any movement of the patient during the treatment stops immediately, and you can restart it once you have refocused everything. So it identifies the lesion correctly, it delivers the energy to the correct area, it identifies the area which are to be saved, and thus makes it a safe delivery, and that is what makes the Focal One different from rest of the energy delivery or in the same field.
Thank you, doctor. The next question that we have received, you mentioned in your previous answer about advanced imaging. So, how does Focal One use advanced imaging and precision technology to target cancerous tissue? Can Focal One help preserve healthy prostate tissue while treating the cancer?
Yes, exactly. That's the base. That's the principle. That treat the cancer, save the organ. So that's the principle. And again, it may be a little bit repetition, but to answer that question, I would say that we have ultrasound images, we have MRI images where the lesion has been identified. They can be fused together. We identify the lesion. We mark the area to be treated in 3 dimension. We mark the areas to be saved. So you can identify the nerves on the 2 sides. We identify on the images the sphincters. We identify the rectum, and keeping these areas safe is the principle behind this delivery method. And then once you have identified all these 3 dimensions, patient is fixed and patient is not moving, then the robotic arm takes over and treat this area safely for you.
Thank you, doctor. The next question that we have received is, how long does the procedure typically take, and what does the recovery process looks like? Are there any risk or limitations associated with Focal One that patients should be aware of?
That's a good question. So it's a day procedure. So it's although it is done under anesthesia, which can be a regional anesthesia like a spinal, or it can be a general anesthesia, because the patient needs to be immobilized. Spinal anesthesia is a good anesthesia because it gives a anal relaxation to put the probe also. And once the patient has been treated, it takes about 30 to 45 minutes for the whole treatment. And once the treatment is done, patient is with catheter. You can remove the catheter the next day, or they can be sent home this evening or the next morning, and you can call the patient and remove the catheter.
Thank you, doctor. The next question that we have received is, what does the availability of Focal One mean for the future of prostate cancer treatment in India?
I think it's a very important development. We have had for a long time patients who are anxious about their disease. When we tell them that you have a low risk disease or you have intermediate risk disease and you could be worthy of not doing anything with them, so they feel like they have a ticking bomb in their body, and they need to get rid of it. But only thing that we had to offer to them was a radical treatment. And consider the patients who are elderly, who have had in this age, say in 70s and 80s, when they have this disease, when you should be able to offer them something limited, something less harmful. You had nothing except the radical treatment to offer them. The second very big area where we look the use of Focal One is the recurrences. That it's a wonderful tool to treat the recurrences, especially after radical prostatectomy, which occur late, and surgery in post radical radiotherapy patients is a disaster with high degree of complications. So if in those patients who have a small recurrence after radiotherapy, again this energy and this equipment and Focal One can be of very, very important use.
Thank you, doctor. The last question that we have here is, what message would you like to share with men who may be hesitant about getting screened or seeking treatment for prostate cancer?
I think the message is that you don't have to be scared. Even the disease, irrespective amount of the developments that have occurred, they have occurred in every area of the field, and we have the methods to treat you. The methods to treat just the disease is sparing your organ, and we can assure that we want to give you the best functional outcome and the best quality of life and treat your disease at the same time.
Thank you very much, Doctor, for your valuable insights and precise time. Please, would you like to share a concluding message that you want to pass on to your audience?
I think don't be scared. The disease, if it is there, we know that the basic principle is to treat the disease and spare the organ. Give the best functional outcome, so that you can enjoy your life even after treatment of the disease, rather than be scared of the treatment.
Right. Thank you, Doctor. Thank you so much. Thank you, our live audience who joined us. I think we are done with the live session today. Thank you so much.
Thank you very much. It was a wonderful opportunity. Thank you so much.